This is a very brief video on why mechanical ventilation is very hazardous in the setting of asthma. So here we are looking at a normal alveolus. On the left side, as you can see, the straw, which represents your airways, is wide. So to exhale a normal tidal volume doesn't take that long in the normal lungs. Whereas in an asthmatic, think of it as a balloon with a very thin straw with a lot of resistance. So the balloon needs much longer time to empty the tidal volume. The concept that is useful is time constant, illustrated in the center. It is it's resistance times compliance. Normally, you need 3 time constants to empty close to 95% of the regular tidal volume. In asthma, you need a lot more time, and it may even be 6 or 9 time constants. Essentially, you need a lot of time for expiration. So if we intubate an asthmatic, we are limited on the respiratory rate because the expiratory time needs to be more than the usual, like 3 seconds or so. You may need 6, 8, or in some cases even 10 seconds to exhale, talking about the worst cases. And if you do not give this expiratory time and deliver the next breath by having a high respiratory rate, you will be over distending the alveoli. This is what we call as air trapping. And air trapping can have some deadly consequences. In addition to the barotrauma is easy to understand. You over distend an alveolus, it's going to rupture, cause pneumothorax or pneumomediastinum. But we have to remember the heart is inside the thorax and it will literally get crushed between your hyperinflated lungs and cannot fill well. That means your cardiac output drops, leading to a picture similar to a tamponade, like an obstructive shock. In addition, the efficacy of the diaphragm also goes away because a normal diaphragm can generate the strength. When your lungs are hyperinflated, the anatomical position of the diaphragm doesn't let you generate the strength that's needed to inflate the lungs against an increased resistance in your airways. They'll be dependent a lot on their accessory muscles. And the increased intrathoracic pressure secondary to air trapping can lead to decreased venous return that worsens your cardiac output as well. And one important physics principle that we have to remember is Poiseuille's law. This will come in many forms throughout uh, human physiology. But as far as applicability to asthma goes, when you have an airway that is like a tiny straw, you have to generate a lot of pressure, delta pressure, to pull the air in. That increases the work of breathing. Sometimes the patient may not be able to do the work of breathing, in which case BiPAP may assist them, but you have to watch that they don't take huge tidal volumes, which will worsen the air trapping problem. The bronchodilators are going to be key. You have to dilate those airways because it's to the power of 4. So a small change in radius will lead to a much better flow. And as the resistance decreases, your time constant also improves so that they can exhale their tidal volume quickly. And at the bottom, I put flow as inversely proportional to the viscosity. This is where heliox comes in. Heliox, you can have 21% oxygen and 79% helium. It markedly increases flow, and the delta P also decreases, the work of breathing decreases, and you can exhale faster as well with Heliox. So Heliox is godsend in severe cases of asthma. You can do it before intubation. That may actually prevent intubation altogether. So reach out for your Heliox early. As I mentioned, this is a very brief video just to give the highlights. Do not intubate a patient without discussion with your intensivist because you may be making things worse. Use low tidal volumes, low respiratory rate. Forget about your PCO2 and pH. It is hypoxia that kills patients, not hypercarbia. Most patients tolerate hypercarbia reasonably well. Do not try to normalize their blood gas. That's how we lead to air trap and barotrauma and an obstructive shock. Use Heliox early. And if you happen to intubate the patient, use ketamine for sedation. Ketamine has bronchodilator properties. Paralyze the patient so that there is no vent dysynchrony. And you have to tolerate a higher peak pressures. It's generally suggested to do volume control so that you take control of the tidal volume so that you decreases the chances of air trapping. And of course, you have to look at your ventilator waveforms for you to get an idea of how much expiratory time you need to give to completely exhale. You can use pressure control, but you have to monitor frequently. As with your bronchodilators and ketamine, the same pressure can give a much higher tidal volume once they bronchodilate. So you can use either mode, but it doesn't obviate the need for being bedside and monitoring closely. Sevoflurane works very well as well. You'll have to talk to your anesthesia colleagues. Reach out to ECMO centers early once you intubate, as VV ECMO uh, can be very helpful in situations of status asthmaticus. Hope this brief video helps.